I've been given the task to talk to you about delirium, assessment, management, trying to keep it as practical as possible. So, there's a few slides obviously going to be quite didactic and stuff, but I'm happy to take any questions as we go along. Okay? I might just start by giving you two cases of mine in the past. And then I want you to think about what is the potential diagnosis, okay? And then as I go through a talk, hopefully we'll get back to this and I'll ask for your thoughts. So, case number one, Mrs. MH, 62 years old. She had a history of early onset Alzheimer's dementia at the age of 55. She was from a dementia-specific nursing home, and her problem, the reason she presented to hospital was because there's apparently been increasing behavioural disturbances in terms of physical and verbal aggression, and then also psychological symptoms in terms of hallucinations. On a background of some deterioration over the preceding sort of 6 months, but more so particularly over the last 2 months prior to hospitalisation, in which period police was called to the facility twice to help sort of control her behaviours. And she was assessed twice in the emergency department. And in fact, she even had a brief admission under psychiatry to try to control her symptoms and signs. She's also been having increasing falls on a combination of antipsychotics, risperidone, haloperidol, and pyrazine benzodiazepine. So that was the cocktail that needed really to kind of, have some sort of degree of hold on this lady. Now on the ward, she was pacing 24/7, literally, intrusive, spontaneous, unpredictable verbal outbursts of very colourful language at everybody, including passers-by and visitors. So it became really a very sort of unpleasant environment even for other patients. But the most disturbing thing was that her aggression tended to be sort of pretty much out of the blue. You can't expect that suddenly she swings a right hook at you. That's Mrs. MH. Case 2, Mrs. RS, 79 years old. Incidentally, they're both female patients. It's not a male versus female thing. It's just coincidental. Mrs. RS from a nursing home as well. She presented with food refusal, increasing agitation, becoming sort of more increasingly teary, and staff were sort of having a lot of difficulties managing her over a period of about a week or so. She had a background of advanced dementia as well, and she's on tricyclics and mirtazapine, presumably mirtazapine for depression, tricyclics for... It's hard to tell what tricyclics are used for these days because GP likes to prescribe it for a little bit of sleep as well. For those who are doing geriatrics, that's probably a bad thing, a no-no. On examination, she was incessantly talking gibberish, not obeying simple command, consistently yelling out, dry crying. You know what I mean by dry crying? It's like what kids do, crying, no tears. Hard to tell whether it's real or not. Vital within normal limits. So not much to go by. So have a think about what the differential diagnosis between case 1 and case 2, whether they're the same, whether they're different. Now, first question I'd like to ask all of you, actually. I'd be surprised if any of you haven't come across a patient with delirium yet. If you haven't, then you're pretty lucky. You must be doing a really fantastic term somewhere in a hospital. Everyone familiar with what delirium is? Can someone yell out scream out or, offer a definition for me before I go into the next screen? Okay. Acute baseline cognition, keywords. Good. Anything else? Another keyword, so acute fluctuation. Yep. Reversible. Okay, reversible is a feature of delirium, not a diagnostic feature, but it is a feature of delirium. Important one. Disorganized. Sorry? Yes, another key one. Okay, so you guys know it all already. It sounds like. Okay, so DSM-5, essentially what you're saying. The main features are the attention, the lack of disturbance in that. So they cannot focus, they can't sustain attention with you, they can't shift attention to something else. okay? And lack of awareness of surrounding, lack of awareness of what's happening. Changing cognition, definitely, and it's pretty much global. It's not just memory, it's insight, it's language, it's perception, it's everything, resembling a patient with dementia. And the key feature is that you can literally define when the onset came on, so it's acute. The onset is hours to days. But we do increasingly see patients developing delirium over the space of a week, depending on what is causing delirium or what is precipitating the delirium episode. And then the other feature is it fluctuates. So in short, acute, the fluctuation, the attention are the main three features that allows you to distinguish it from the other common differential diagnosis I'll go through later, which are dementia, depression, and other sort of psychiatric problems. Okay, because cognition can happen in all those other conditions as well. Now, reversible. Okay, the teaching is that there's a cause for delirium. It's always nice to find one, and you should always try to find a cause or a precipitant. But don't be surprised now and then, despite exhaustive investigation. We see that quite common in geriatrics sometimes. In particular, the patients who has a predisposing risk. So if they've got dementia already, it doesn't take much to set them up into delirium. So the change in weather, for example, change of environment. And, you can do all the tests you like, but you won't find a cause because unless you specifically ask a very detailed history, you won't find out that is actually the cause. Just a change in environment sets them off. But we always get told that there is a cause, it's reversible. It's not 100% of the time. So just to go through some clinical features, okay? The acute onset, as I said, usually hours, days in terms of onset, but it can be abrupt. I've had I don't know whether I told some of my team members here, I've had a patient who had intellectual disability. He was going A-OK, 62-year-old man working in an animal farm. Went to work one day, nothing per usual. Suddenly he became absolutely delirious as a kite, becoming incontinent, unable to walk, doesn't make sense, doesn't recognize people looking after him. So that's the kind of thing that we're talking about. It can actually happen just like that. Now, the initial symptoms can be certainly, it can be mild, it can be quite severe. There's a spectrum, okay? The common clinical features: daytime somnolence, fatigue, decreased concentration, irritability, restlessness, be anxious, be agitated, and some degree of cognition impairment, sometimes not that obvious. You can have a copy of this slide if you want. You don't have to write down things. Now, disturbance of consciousness. We've often talked about the patient can be literally in a semi-comatose state to a state whereby they are as high as a kite, whereby they're, you can't keep them down for any second, okay? So hyper alert to comatose, essentially, the spectrum between them. In the inattention I've mentioned about, very easily distractible. Fluctuation, okay. The fluctuation, we often get taught about the fact that it happens over a space of a day or two, but don't be surprised you come across a patient who fluctuates pretty much within the hours. I've seen the worst case where the patient fluctuates pretty much within minutes, That's how severe it can be. And don't be surprised also when the family tells you, doc, she was fine this morning. That would be something to do with the fact that they have this period of lucidity where they seem to make perfect sense. And then other times of the day, they don't make perfect sense. So that's the fluctuation. Now that's in contrast to a patient with dementia, whereby, they're quite consistent. It doesn't matter what time of the day. But then nighttime, they have this consistent feature. They're always worse. And that's the sundowning that I'm sure that's some of you might have heard of already. So that's quite different, the fluctuation versus sundown. That's quite predictable. Every night, they go off. This one's not so predictable. The psychomotor disturbance, I said before, restless, agitation, just physical things, inactive, disinterested, social withdrawal, etc. And there's the disorder of thought, as someone mentioned. So that relates to everything, the illogical, the irrational, doesn't make sense. Their paranoia. And the paranoia can be to do with their loved ones. It can be to do with you, the treating doctor. And obviously they lack judgment and insight and understanding of what's happening currently. Okay, language, okay, they might have trouble speaking, understanding. So all those things that you will get in a demented patient, you get this sort of similar thing. Now, with the memory, it tends to be obviously the short-term stuff rather than the long-term memory. Again, it doesn't allow you to differentiate for the dementia patients. They tend to confabulate. Okay, just run through this. Perceptual disturbance, all sorts. There's none of these perceptual disturbances are pathognomonic or characteristic of delirium, but it can be a feature of delirium. Any of them can be in combination, it can be just one of those things. Typically, hallucination is more common than the others. Sleep and wakefulness disturbance is a very, very, very common common feature. Typically what happens is they don't sleep during the night, they wander everywhere, and then they get tired during the day, then they sleep, and then the cycle just keeps repeating. So part of your management strategy is, as the treating doctor, is to somehow advise nursing staff to do whatever they can and relatives to do whatever they can to keep that patient awake as possible. What you want to do is you don't want to give them medication to sedate them necessarily. You want to just tire them out during the day, so that helps you to minimize any medication usage to sedate them to sleep at night. Okay, to somehow reverse that. It's not easy in the acute hospital sort of setting because you tend to have, in our geriatric ward, obviously we've got a couple of fused patients happening simultaneously. So, they set each other off. Even in yes? What do you think? Yeah, just don't take them off just like that. You got to wean them off slowly. Yes, I would take them off, but you got to wean them off. Okay. It's most likely benzos don't work after a while. Most people they have this psychological dependence. And honestly, if you have a placebo and you trade the placebo for the real thing, they probably wouldn't even notice. So it doesn't work when they take it chronically like that. Okay. Does delirium present similarly in all patients? I'm sure that you agree with that answer in the red already. It's not meant to pop up like that. It's meant to fly in, but anyway. No. Oh. Okay. I think I mentioned earlier that we talk about the three, the variations in the level of alertness, okay? So classically, we talk about hyperactive delirium, hypoactive delirium. And then obviously there's the one that's mixed. That's probably the more difficult to manage. The ones who are at sometimes really aggressive and agitated, other times they are literally comatose. That is the challenge. All you hope for is that everyone understands, nursing staff, doctors, after hours, JMOs, doctors, etc., understand that is what's happening, and not to sort of get overzealous and start sort of medicating the hyperactive period, because then, things just get out of control. Okay. This is what I'm talking about. So the hyperactive state is obviously the aggressive agitation, restlessness, and all the vital signs are a bit on the sort of higher side of the reading. The hypoactive state is that patient whereby you start to think like, is this patient depressed, catatonic depression state or something like that? That's how bad it can be. And then most often is this increasing number of patients who have mixed clinical features. How common? And you need to know about it, and you're getting these lectures on a regular basis because it's so common. We have an aging population, so increasing prevalence of dementia, etc. And you'll have patients with delirium more and more. Very common. Hands up those who work in the orthopedic unit. 1, 2, yeah, delirium. You guys know all about delirium. So the other surgical unit, how about neurosurgery? You come across the delirium patient quite often? Which type? The not so active type? I'm guessing it's a not so active type because hyperactive as well. Yeah. Hypo. So you get a mixed bag. And then the geriatrics guy would be, everything goes. There are special populations who tend to be more prone to developing delirium. Okay, so nursing home residents, patients with pre-existing cognitive impairment of any kind, including some degree of intellectual disability, not just dementia, intellectual disability and mild cognitive impairment. Okay, and then the other hospital patients are the surgical ones, the cardiothoracic patients, orthopedic, hip fracture, big ones, ICU patients. And obviously, not surprisingly, palliative care patients. You need to know about it because delirium is bad. Yes. Age is the big one, followed by comorbidities, especially cognition. So the young ones don't tend to get delirium. They contain a lot of insult. That's because the brain's working fine, and the age risk is not there. And it probably has a low sort of comorbidity burden as well. Yeah. That's why they don't tend to develop delirium. So there's lots of adverse outcomes, proven scientifically, okay? Administration is probably concerned about the first one, increased length of hospital stay. That is no, it's very bad. You have to do your discharge summary quick and sort things out as quick as you can. Functional decline, we see it all, in especially the ones above age 70, the ones with pre-existing cognitive impairment, pressure sores, incontinence, falls, fractures, etc. All these increases their risk of being institutionalized. And delirium on its own, independent of the cause of the precipitant, has a mortality rate of roughly about 30% in the first month. So it's almost like having a big heart attack. But you don't appreciate that because a big heart attack, you can see it, it freaks you out. You're witnessing the patient decompensating, where delirium is kind of like rumbling along, so you don't quite appreciate it as much. But the mortality is high on its own. Who gets delirium? Okay. Cognitive frailty, very broad terminology there, but that's because despite years and years and years of research and all sorts of scientists come up with explanations of the neurobiology, neurophysiology and all that kind of stuff explaining delirium, there's tons of neurotransmitters involved. You can't pinpoint one exact thing that causes it. Everybody agrees that cognitive frailty, so if you have some degree of cognitive deficits of any cause, plus you are challenged in any sort of metabolic situation, whether it's sepsis, whether it's infarction, whether it's stroke, etc., and that exceeds your physiological reserve, then you are more prone to delirium. So essentially, predisposing factors plus precipitating factors. So predisposing factors are such things as age, and I'm going to throw this term in. I haven't mentioned it before because it's a big topic on its own. Frailty, age, frailty, cognition, that's your predisposing factors. Precipitating ones are your systemic challenge, whether it's infection, whether it's a heart attack, whether it's a stroke, etc. Okay? That obviously sets you up into a delirium. And that probably explains why a lot of old people, when, you get a lot of people who come into hospital, they're not that confused, and then they become more confused. We see it all the time in our geriatric patients. That's because complications, things that happens in hospital is very overwhelming for these patients. Am I going too fast? Okay, because you know pretty much all of it already. Almost. Okay. Common causes and precipitants. You know what? That's not an exhaustive list, but that's all I can fit into one slide without making it really, really disgustingly messy. Okay? And in terms of categorizing everything. I'm just going to throw it out to you guys there, okay? So for example, if you saw a patient who is admitted for confusion and you are working in coronary care, right? So coronary care, let's say a patient would come up with some sort of cardiac diagnosis and the patient's in a delirium as well. Who's in coronary care at the moment? Anybody? That might be a silly question. Do you do CCU in first year? Oh, okay. Well, let's take a guess. just for the heck of it. What do you think could be the cause of a patient who's admitted into the cardiac ward with a cardiac condition? You can ask me a question before answering if you wish. Like, how old is the patient? Maybe. It's not necessarily right. You can say those things. It's not necessarily right. This is context-based question. So a 70-year-old with AMI and confusion. Should you investigate further the cause of the confusion? Are you happy to say that the AMI is caused the confusion or what? Yes. Okay, yeah. Morphine's bad, yeah. Good for chest pain. Anyone else? Are they having a stroke? Okay, that's a fair thing as well. That would be rather obvious, isn't it, when you examine the patient, moving arms, legs, facial droop, all that kind of stuff. Yeah. Okay, so I think you guys are thinking the right way, I think. Yes, the AMI might be causing the... Okay, so I was hoping someone would ask me, okay, number one, how old is the patient? Number two is like what possible background they may have. Like, for example, it might be a patient with some degree of dementia pre-existing. Having a simple... Even having an angina can set them off. Even having a TIA can make them go into delirium, right? So that's important to know. So a bit of the background information, what the predisposing risk factor is, followed by anything you can find electrolyte disturbance associated with the event. Yes, absolutely, present infection. But what I'm saying is that you might have a cause, right? If they've got predisposing risk factors, sure. You can be happy that bloods are okay, all kind of stuff. The AMI might explain that that's enough. You don't need to go crazy getting CT brain and all that kind of stuff in the absence of focal neurology. It's not routine, okay? So that's fine. But if you had a patient who was absolutely pristine, cognitively fine, independent, driving, doing the banking observes, etc., had a heart attack and they are in a delirium as well, then you should probably aggressively investigate for additional things that might set this person off other than the AMI. Okay, so I'm getting at. So if you were, post-op setting, orthopedics, orthopedics. Your patient seems to be fine pre-op, comes out of theatre, and the nurses are calling you, oh, Mr. So-and-so is climbing out of bed, he's swearing, all this kind of stuff. What do? Just treat, investigate, or, yeah? For what? That's a good idea, yeah. There's something else a bit sort of easier before that. What was that? I think I heard someone said Bible. Examine, okay. Examine's good, yep. Examine. Just be sensible with examination of the delirious patient. Like, for example, if they're kind of like they're thrashing about, it's okay. Just say, maybe there's nothing neurological for the time being. You know what I mean? No, we have people, it's being kicked and punched accidentally. So, yep, examine. Vital signs. Just in case they're hypotensive, tachycardic, bradycardic, hypoxic, Because then you can just, instead of going crazy investigating all sorts of stuff, you can just hone in what's abnormal. That's probably the cause. Let's say you did that, everything looks fine. Look at the bloods, it looks fine. Vital signs are okay. Maybe just surgery. You look back in the history. Yeah. I think half of your patients were nursing home. They tend to be chronically impaired to a degree, I think. If you search enough, you'll find it in the history. So quite often the surgery and the insult that happens there is enough to set them off, and post-operatively they get confused. So go with context of the patient. Okay, did you read all that already? Perfect. I thought I put this in because sometimes the most simple things get quite overlooked because we always strive to find like a good diagnosis. So, like an infarct or a stroke or something fancy or cold sepsis and stuff. And then forget the simple things like the patient was on long-term benzo. We have such patients who we forget to write the benzo on for like 3 or 4 days before we realize it. We do run into that situation. And believe it or not, old people, they do like to grog a bit. We do have patients who drink quite a bit and they go into withdrawal unexpectedly. If you don't get that in the history, you don't give them the thiamine, go off, and then you play catch up. But constipation and urine retention happens very, very, very commonly in hospitalized patients who are immobilized, stuck in bed. It's functional retention. Nothing sinister, but it's enough to cause you problems. The red sentence, multiple factors. You need to treat them all. But you have to kind of tailor your investigations to the context of your patient. Okay? That's what I mean by treat all the symptoms. So assessment, oh God, that's all. The assessment to diagnose delirium is all pretty much talking, look at that, history of past psychiatric problems, medical things, current medications, family history, personal history, pre-morbid cognitive status. That's not in order, just in case you're wondering, okay? That's not in order of importance because if it's order of importance, which one's number one? This one? You can debate about this one and this one, I like to think it's that one and then that one, and the rest. Oh, gosh. Okay, delirium screening tools. You can do these tools, but quite often, if you get a decent history, you'll be able to tell that your patient has delirium as opposed to anything else. But obviously that relies on collateral history from someone who knows the patient, someone who lives with the patient. If you don't have that, unfortunately, you just have to rely on best diagnosis possible and the screening tool. 2 main screening tools. You guys should pick me up and say, no, that's actually only one of them is a screening tool. The first one is the real screening tool for delirium, not the second, right? I put the second there because a lot of people do it. I don't know why. They do it. Now, the first one is called CAN, which stands for Confusion Assessment Method. It's very easy to use. Nursing staff tend to do that. You just have to look for I'm a bit embarrassed to say, I forgot what color it is. It comes sometimes blue, sometimes it's white. You guys remember what color it is? Have you guys seen it in our wards? The CAM, white? Yeah, ours is white. Another hospital. Work it is blue, doesn't matter. The features are the same, the sentence, the questions are the same. It's very easy to do that. It's pretty much what it says there. That's what you ask the patient and the person who provides the collateral history. Very simple to score. You need the first 2, this one. You need to have this one, plus or minus one of these. And that's your diagnosis of delirium. Notice I say diagnosis. It's a screening tool. Technically, it's not diagnosis, but, for what? For all intent and purposes. It tells you that the probability of delirium is highly likely. The mini mental, the reason I put this on is just to remind you that the features, the reason people do it, because remember the diagnostic criteria, attention, memory, awareness, all that kind of stuff. Well, the features in here, you see attention and orientation. So it's part of that, and that's why people use the mini mental as a screening tool, but it's not validated for it. Okay, differential diagnosis. Okay, can someone suggest certain features that might allow you to distinguish between a patient suffering depression and delirium? Fluctuation, yeah. Degree of cognitive impairment. Pseudodementia. So what kind of cognitive impairment do you get with a depressed patient? Is it the type whereby you ask them something they don't seem to know because they look like they're not even trying? And then if you keep pressing hard enough and they give it a go, they actually get the right answer. Is that what you mean by that? pseudo. Yeah, generally that's what happens. You know, you're not interested. Don't care. But if you try hard enough, they give you the right answer. Yes, fluctuation's a key thing. Acute onset, absolutely. The main first 2 or 3 criteria of the delirium allows you to differentiate that very easily. This is for you to have a look at. We've spoken about the onset already. Dementia is obviously typically insidious. It could be months. It's typically months to years in decline. Of course, as you can see, dementia is slow. Duration, months, years. Now, attention, okay. Mild dementia, attention's intact. Moderate advanced, they go. So attention's unreliable in the moderate and severe stage of dementia. Okay. Sleep-wake cycle, it says here usually normal for dementia. That's only mild dementia, early part of dementia. In the severe, as you know, the advanced dementia, they're the same. It even fluctuates the same way like a delirium. So it becomes very difficult to distinguish. That's why I feel fatigued when I get a patient with advanced dementia with the presenting history of more confused than normal. It's like, I'm like, oh my God, how are we going to work this one out? That's pretty much relying on what you get from the person providing the history. It's nearly impossible. Same with alertness. Advanced dementia, the alertness altered, fractured, impaired, just like a delirium patient. And then all the rest you can read in your own spare time. Okay. The reason I put that on its own, it is true, a delirium is technically an emergency, not in the way like a Met call emergency, but it does warrant your relatively sort of, rapid sort of attention, okay? On your JMO lecture guidelines thing, one of them said that I should talk to you guys about communication technique. Has any one of you had to tackle a delirious patient after hours yet? You did? Sorry. That's a good one. Okay, I don't mean tackle like that. I mean, you had to assess a patient with delirium. I have had someone said that to me for a long time. That's why I'm smiling. Okay. Sorry, did you have an encounter having to assess a patient delirium? Or? In where? ED. Oh, that's a perfect place to do it. Okay, so were you the first doctor to see him? So tell us what, if you don't mind, tell us what you, how you went about trying to settle the situation. Yeah. Well, that's pretty good. I mean, you did apply some of these strategies already, what you've just described. Yes, it's always good allowing someone, especially nursing staff who are very experienced, because at your level, you're the least experienced. So that's good. That's being sensible. I suppose the first question I would ask is like, there's a slide later on that says the don'ts and the do's, but I'm just wondering, did that patient need to be catheterized? That argues for not catheterizing. Yeah. Anyway, so I'll talk to you about that, right? So I mean, you can't do much. You cannot do anything to reverse his encephalopathy any time sooner than the natural course of treatment, etc. But yeah, all these things you do, and in that setting, especially in ED, where the chaos happens outside, the lights going, and you're not exactly in the room, etc. Yeah, it doesn't help. You've got to have the ideal environment to do everything correctly. So even this, you might apply all these good communication techniques, but if you've got lots of things happening behind you, you know how they're usually very distractible, easily agitated, stimulated. Stimulation not good for the patient, but that doesn't help despite your communication technique. But this is what you need to do first. You and the patient, one-on-one, eye contact, etc. Speak slowly, clearly, all that kind of stuff. And 1, 2, 3. The 5th point, it says appear interested. That's not me telling you to pretend to be interested. You have to be genuine, obviously, just like every patient you encounter. But sometimes a patient may be confused, but they can pick up the subtleties very easily, and that sets them off even more. The last point, do not forget the last point. Yes, it's your job to see the patient. Yes, it's your job to assess the patient. But at the same time, it's also your job to be safe and others around you to be safe. So if a delirious patient is really big and aggressive, etc., then there's no need to go crazy practicing communication technique and try to develop rapport, because you just might get a smack. And that's not good for everybody. So this is where you might think about getting other staff or /security involvement. When do you do that? Usually nursing staff will be onto it before you do. So that's a good thing about it, because they know, how things will sort of head, whether things head south really quickly or not. Okay, so that they normally will initiate that independent of you anyway. And just to let you know, so under what circumstances, so how do you know when you're allowed to do such things? You just let the nurse dictate, or can you can you call security any time you wish? Hopefully in consultation with the nursing staff who looks after the patient, obviously, and if any nursing staff say you need to schedule the patient, try to involve the senior doctor around, so the registrar, okay? When it gets to that stage, when security is involved and stuff, involve the registrar, because they know how things should be carried forward in the sense of when does a patient need to be scheduled, when a patient does not need to be scheduled, and they can be retained with the help of security under the duty of care. So typically, with our geriatric patients, they have dementia, they lack insight, understand that kind of stuff. We don't necessarily need to schedule the patient. They would be, security guys would be able to help to control the patient under us, our duty of care. Other wards, like for example, I suppose if it's a young person with encephalopathy or something like that, then you might just have to schedule them. You can schedule the patient, but if you're not comfortable, get the senior doctor involved. And always ring, whichever consult looks like the patient. Not you, but just in case the registrar's not around, etc. You always do. Okay. Any questions for that? When in doubt, call the senior doctor. Okay, don't. That's why I asked for you about catheterization. If it's absolutely not needed, don't catheterize, don't cannules, that's it. Do not use restraint unless pretty much it's a last dire straight situation. Use restraint, but even then, we still try to not do it. Like for example, you have patients who might be pulling the NG, pulling the peg tube, pulling the cannula, pulling the drip line, whatever, right? Pulling the cast off, whatever you like. Instead of restraining them, you can actually just not restrain, you restrict the movements of, the grabbing action. For example, you can put a mitt, a glove, etc. Yes, that can be viewed as a form of restraint. That's certainly better than it's because this actually does more damage than more harm than any good. We've had patients who actually broke their wrist because they keep doing this, yanking on the thing, and they break their legs. Do not sedate routinely. We'll go through the antipsychotic use and stuff like that, right? But don't sedate routinely because, number one, you're just shutting down the problem. The idea is that the patient's confused, and the confusion, the delirium will settle when the treatment of the precipitating condition takes effect. It's just a matter of time. The idea is you don't sedate them, you're just trying to take the edge of their agitation. So the purpose of anything you do for the patient, including drugs, is not to sedate. I don't know why I put don't argue with the patient, because that would be rather obvious. Be surprised at. Okay, having said all that, investigations. Okay. Investigations, like I said, it has to be in the context of the patient you're dealing with, whether that's orthopedic patient, post-operative patient, as opposed to other patients, other ward, right? So your investigations will dictate that. This is not any particular order, but obviously we all agree that physical examination is the first part, right? What's the second part? What goes after physical examination amongst that? Medication, who said that? That's good. Medication review, okay. So if your context, right? Sorry, I keep reading this. Context. If you're looking after the patient and they're going, okay, suddenly you come next day and suddenly says, oh, your patient's confused. Delirious. I go, why? What happened? Are they sick? Or the first thing is, yes, medication checkup. Especially, you're working the surgical ward, pain management, stuff like that. Maybe they've been prescribed something that has set them off. So that's the first thing to do, look at the medication. Yeah? What's the next one after that? Sorry, the vital signs stuff is part of physical exam. Okay, I didn't put it so. Be yourself. Yeah, okay, commonly enough. Forget that patients are, I think it's very common. Sometimes some patients are actually not on tablets. They're going okay. But when they're hospital, they're not eating very much and stuff like that. And so they get a bit hypo. So yes, be yourself. EC. Why ECG? Routinely, or is it based on the fact that maybe if they have lots of ED? ED is good. ED does routinely ECG and chest X-ray. Outside of ED. Okay, so maybe if they've got all the vascular risk factors, they've got ischemic heart disease and stuff like that, then you might think about doing ECG. Yes, if they're confused, they're not going to tell you they've got chest pain. Sorry, yeah, you might think about doing that. And obviously, if you do an ECG, is there a point of doing troponin? Or yes, it has to be a troponin special. Hey, what's the point of doing ECG without troponin, right? I don't know. Don't you need a troponin to go with ECG? It's kind of like the right arm, left arm. Okay, when you do cardiology next year, can you find that out and let me know? Because I like to think that, if I do an ECG, I do a troponin. You can actually go the other way around, in fact. You do a troponin first, and it's normal you don't do an ECG. There's a trick. Okay, CT brain. Where does that come in, CT brain? A delirious patient, do you get the CT brain or not? Depends. This is a leading question here. I said depends. Depends, yeah? Cool, okay, all right. So in other words, if you can't find obvious focal neurology yet, just find other systemic things, yeah? Good. The reason I say that is when you're in ED, try to not sedate patients for CT brain. You can, restrain yourself. It's quite often they do that, even though they have other explanations, and I'm wondering what the heck for, because they make the patient even worse afterwards. When they wake up, they're more angry. So yeah, don't do that unless you have no cause. You can find. That's when I go to CT brain, or you've got focal neurology. Okay. Yeah, where is that? Oh my God, I didn't put it there. That must be part of the septic workup, sorry. So that's urinalysis, urine microscopy, and chest X-ray, and that kind of So obviously that's dictated by the history, yeah? Okay. LP. We do LP? Not sure, I like it, good. If your answer's not sure, yes, usually you kind of go non-invasive, like this. LP is the last one. Unless your history, your physical examination is like clearly screaming encephalitis, meningitis at you, that's when you go ahead doing early LP. But otherwise, it's pretty much the end of the line. Even circumstances, we do CT. If CT is negative, we do MR if possible, then LP. Because obviously you have to sedate the patient for the LP and you can't really sedate on the ward, etc. because you need airway protection and it gets really messy. That's why. Okay, so you try all these non-pharmacological stuff, dim down the light, feed massage for the nursing staff who's really good with the patient, you talk to the patient, you get the family involved, analgesia, etc. It's still, difficult. Then you're going to go, okay, we need drugs. Because drugs can be useful. Sometimes you just employ non-pharmacological stuff in combination with drugs. Okay, so what drugs do you use? Who's used haloperidol? You stick your hand up if you've given a haloperidol, whether during hours or after hours? Really? No. Only one of you? Wow, that's pretty good. You guys are really being brought up well by somebody. That's good. Okay. All right. So in short, antipsychotic doesn't really do anything to the delirium. It's only we are taking the edge of their restlessness, agitation stuff. Okay. It doesn't shorten the duration of the delirium. It doesn't make delirium any better. It doesn't get rid of the delirium. So we're just really managing the safety of the patient and those who look after the patient. That's pretty much it. Okay? Yes, there are certain symptoms that antipsychotics are specific for, so hallucinations, paranoia, stuff like that. Yes, those are the symptoms we tend to employ antipsychotics independent of their agitation and aggression. Because if the patient finds the hallucinations, paranoia disturbing, or the carer, we normally treat the patient first, followed by the carer. Okay? Just to make that clear. But we treat this. Now, in the setting of delirium, haloperidol is the first line. So acute usage, intermittent PRN, stat doses, etc., haloperidol works best. It's least sedating, but it's very effective in taking the edge off. And it's got the most sort of scientific data supporting that kind of usage. That's haloperidol. Who knows why it's not good to be using haloperidol too often, too prolonged. Sorry? I get this tonic? What is that? What's this tonic? So you're talking about the extrapyramidal side effects thing? Yes, absolutely. Because it blocks, it's a very potent dopamine. So that's why it does. Benzodiazepines. We generally avoid benzodiazepine. The only time it gets used is probably when someone's trying to CT the patient's head in ED and they have to give it midazolam. That's, yeah. And psychotic patients. Yes. QT prolongation, all that kind of stuff. Yeah. There's a lot. We don't have time to go through, but there's a lot of. And antipsychotic side effects are nasty long term, so we try not to use it long term. We only tend to use it for end stage. So benzodiazepine, yes, look, it may worsen delirium. Okay, it might have the rebound effect. That's why we don't use it. Exceptions to the rule, obviously, alcohol withdrawal, no choice. And also, if they've been on benzodiazepine long term, you can kind of wean them off. How do you wean someone off benzodiazepine? Like if they've been on Valium? What do you use? Another benzo or something? Yes. Good. Okay. So if they're on temazepam for God knows 10 years. Wind it up. Okay. Yeah, you put them on a long-acting Valium and you wean it out. Okay, the choice of drug depends. Okay, these are the doses. If you forget, just think about 2 milligrams, 3 milligrams maximum doses. There's some drugs that you can use orally, risperidone, quetiapine, or olanzapine is very useful. Comes as IM as well. But you guys can have this slide. You don't need to. Okay. but gentle and slow, because especially if they haven't had such things before. And the reason why you don't give it too often, you don't give it for long, is because of this. You have patients in ED sometimes giving a shot of morphine followed by half an hour, get a shot of haloperidol. They were 20 minutes still aggressive, they get another shot of olanzapine. And then guess what? 4 or 6 hours later, everything comes to like a build-up, and then the patient's semi-comatose. So try to avoid that situation. Just be patient. Okay. Bad prognosis. Okay, I have to wrap it up. You can have this slide to read. Okay. Any quick questions? Beautiful.